Thank you very much for offering this platform. And I welcome all of you to this session of ISTK PG Clinics. Today we have Professor Shobhana Bhatia as the lead faculty, and myself and Professor Jayanti ma'am is also here as faculty. And the case will be presented by Dr. Anup Pavlos, who is a senior resident from Amala Institute of Medical Sciences. The discussants for today's class are Dr. Manmohan and Dr. Ramya, both from Madras Medical Mission, Chennai. Professor Shobhana Bhatia hasn't yet logged in. We hope Professor Bhatia will be able to log in soon. And in the meantime, we will start the case.
Yeah, VT, she's traveling, so she'll join. Okay. Yeah. So she told me to start the session.
Okay. Dr. Anup,
all the people not participating, please switch off your video.
Okay, the house rule is that except the active discussant and the faculty, all of you keep your audio and video in the off position. This is to save bandwidth. Okay, so when the other two discussants are discussing, you can switch on your video and audio. But until then, except the faculty and the presenter, all others, please keep your audio and video in the off mode. Okay, Dr. Anup, you can start.
We have 1 minute. We have only one case for discussion today.
Pardon?
Only one case, no?
Mainly one case. If there is time, we will have some OSCE on esophagus or some presentation. Okay.
Okay. So whatever case you're presenting, this will be a short case in the exam. Okay.
Dysphagia will be a short case in the exam.
Or a ward round. Either a ward round or a short case. So ward round discussion we take towards the end. Short, quick questions and. The case presentation can be a short case. So make your presentation.
Yes, madam. Shall I start?
Please start.
Good evening, everyone. Today, my case, patient Mr. A, 50 years old, coming from Thrissur. He's a manual labor by occupation. His presenting complaints are difficulty in swallowing since 3 months duration. Loss of weight from 63 kg to 45 kg in 3 months duration. Loss of appetite of 3 months duration.
I'll just stop here. Okay?
Yes, madam.
Yeah. Now just see your chief complainant. Everything is 3 months. Is it possible? Is it possible that a person with difficulty in swallowing has weight loss and loss of appetite at 3 months? Is it possible?
Actually, the patient told like he mainly noticed the symptoms which he had difficulty in swallowing, but mainly he noticed for past 3 months. At that time only he noticed about the loss of weight also.
Is it possible, I'm asking you, a person who has difficulty in swallowing has a simultaneous loss of appetite and weight? That's what I'm asking. Is it possible? Like I have one minute. I have difficulty in swallowing today. Can I have a loss of weight and appetite from today?
No, if any malignancy is underlying is there can be cachexia, the inflammatory interleukins which causes...
I know. The ma'am is asking that question because chronologically, see the weight loss in a case of dysphagia occurs after a period of lack of enough food intake. Okay. So yes, if you have weight loss from the beginning, that means, and loss of appetite, it means it is something else. That's the way you have to explain. The most common cause of progressive dysphagia in this age group may be neoplasm of the esophagus. So for which the appetite is generally well preserved initially and the weight is well preserved. Only over a period of time, they will lose weight, no?
Yes, sir. Yes, sir.
You understood. That is what ma'am is asking. So from your history, it looks a little difficult to accept the fact that everything occurred simultaneously.
Okay, sir.
Okay. That was the gist of ma'am's asking the question.
Yes, sir.
So when you take present history also, don't vaguely do like this because seasoned examiners say Jayanti ma'am caught you in the first minute because yes, she's a seasoned teacher, very senior, very experienced, and knows this sort of things very well. That is why you are immediately asked to stop. Okay.
Yes, sir.
Okay. Yes, sir. We'll be stopping you. We'll be asking you questions, but don't get offended. This is purely a clinical academic discussion. Okay.
Yes, sir.
And the other important thing is when you have something all together, just say difficulty in swallowing with anorexia and weight loss for 3 months. No?
3 months. Okay, madam.
Yeah, don't say difficulty in swallowing for 3 months, loss of weight for 3 months, loss of appetite. Okay, it's not since, it is for, no? For.
For, madam.
And just a small a small takeoff from here. Professor Vinay Kumar's point, which I really enjoyed, was this: like if you have, say, a sea of the stomach. Now these patients will have loss of weight and appetite, and then they'll have vomiting. So larger the lumen, anorexia and weight loss will precede the onset of the local mechanical obstruction. Smaller the lumen. Venkateshwar Rao, can you please switch off your audio? You're disturbing the presentation. Dr. Venkateshwar Rao, please mute yourself.
Or for us, can you move to Venkateshwar Rao?
He's disturbing.
His audio is muted. Okay.
Done, sir. Muted.
Yeah. So supposing you have a pathology in the esophagus or descending colon or the small intestine, they'll present first with mechanical presentation, no obstruction. Yeah.
Yes,
and then anorexia and weight loss will come on much later.
Later.
Yeah.
Yes,
So remember that. Even if the patient says that, you can bring the history saying that there's difficulty in swallowing for 3 months. And with a recent noticeable loss of weight and appetite for the last 4 weeks or 6 weeks or something.
yes, madam. Understood.
Continue.
History of presenting complaints. 50-year-old male patient presented with a history of difficulty in swallowing of 3 months duration. It was insidious in onset, gradual in progression. Initially, he noticed difficulty to solid foods. He was able to swallow food with normal chewing, which later on he had to chew more time before swallowing. Patient also felt sticky sensation of food in the lower part of chest. This was also associated with the regurgitation of undigested food particles, which was minimal in amount, non-foul smelling, non-bilious, not blood state. In view of these complaints, he changed his diet to semi-solid for the past 2 months, 2-month duration, and was swallowing with difficulty. Now, for the past 1 to 2 weeks, he is able to swallow only liquids with a mild difficulty. There is no history of any difficulty in initiation of swallowing, no history of choking or nasal regurgitation, no history of any cough associated with swallowing, no history of any change in tone, voice, drooling of saliva, deviation of angle of mouth, no history of any involuntary movements, weakness of limbs, drooping of eyelids, tremor or gait disturbance, no history of any painful swallowing or vomiting.
Just hold on. Just hold on.
Madam?
Just hold on. Just go back, because then you'll lose track of what's happening. No?
Yes,
now, this particular patient, why did you ask for deviation of angle of mouth and involuntary movement and weakness of limbs and all that?
Madam, I wanted to rule out any neurological cause of dysphagia, the oropharyngeal cause of dysphagia. The patient
but you said the patient, this is very important, no? What is it that you want to convey? Is it in the act of swallowing, or is it the passage of food along the esophagus that he has difficulty? You already narrated that he's got stickiness in the lower portion of the chest. And then in an outpatient clinic, this patient comes to the outpatient clinic and it gives you this history. Would you spend time asking, do you have deviation of angle of mouth? Would you ask for history of weakness of the limbs? Will you ask any of these questions? On the other hand, those patients will say that I had a stroke and ever since that time I have difficulty. So the history will start there.
Yes, madam. Yes, madam.
I hope you're understanding what I'm trying to convey.
I understand, madam. I understood, madam.
Yeah, so what the rest of the question that you mentioned is fine. Choking, nasal regurgitation, all that is fine. That is fine. But even to say no history of difficulty in initiation, I'll ask you a question here. Let's hold on here. What are the conditions when you have difficulty in initiation of swallowing?
Madam, any condition?
What was in your mind when you asked the question in this particular patient who has difficulty in swallowing?
I wanted to rule out any causes of oropharyngeal dysphagia because of any neurological causes like any stroke, trauma to the brain, myasthenia gravis, any cricopharyngeal bar, or also any Parkinsonism, any cerebral palsy, Parkinsonism disease. Such
patients will present with neurological symptoms.
Firstly, followed by
and these are all spotters, no? Parkinsonism, you should be able to make a spot diagnosis when you go around in the ward. You just see the patient's faces and you say, oh, it's Parkinsonism, and then you ask, you have difficulty in swallowing.
Yes, madam.
But in a patient like this, now, one important thing is, at least in Tamil, we say, no, that is swallowing, no? But it's
Yes,
not
ma'am.
only the swallowing that you have to ask. You have to say that when you take the food and roll it into your mouth, do you find the food food that you've taken bolus passes through and through into this lower end, or do you find that there's a hold up? That is what is the swallow reflex.
Yes, madam.
Because in English, swallowing is, when you say swallow in English, it's just rolling the tongue and rolling the bolus into the oral cavity, oropharyngeal.
Yes, madam.
That is true. The rest of it is all involuntary.
Involuntary. Yes,
So,
madam.
so some of the patients may not get that history at all. But when you ask a little further, they'll say, yes, doctor, that is my difficulty. I'm able to roll the foot, but the foot is not going down and I have to take water to push the foot down.
Yes, madam. Understood.
Have you understood?
I understood, madam.
So that will be there. And therefore, in this particular patient, I will not bring in this history of deviation of angle of mouth itself. You have to identify this on examination. No? How will the patient say about deviation of the mouth?
The patient didn't notice, bystander didn't notice any deviation by
No.
smiling.
No, but that patient will give out that history, that he has problem. They'll give that history. Yeah. Certain things is that they'll give the history and then to take off from there.
Yes, madam.
Okay, to me, I will not ask for involuntary movement. You know what will happen? Questions will all get to neurological conditions. What is dermatomyositis? What's the present myasthenia? What are the other conditions? Oropharyngeal dysphagia? What is Valdes syndrome? Right and left, they'll be bombarding the questions with that. Tremors of the weakness of the limbs. What weakness of the limb? Which limb weakness are you talking about causing dysphagia? Which condition is this? You will not have an answer. You will not have an answer. Weakness of limbs. What is weakness of limbs and dysphagia?
Myasthenia gravis, even
Now tell, what will be when will you suspect myasthenia gravis? In a given patient, in the clinical history, when will you suspect myasthenia gravis? You're after myasthenia gravis. What will be the classical presentation of myasthenia gravis?
Towards the evening, the patient will be having more difficulty in swallowing of the...
Evening, why in the evening? Is it so that in the evening they'll have difficulty in swallowing and morning?
Evening is for skeletal muscles, no?
For a fatigue, yeah. Why should a person with myasthenia get weakness in the evening for swallowing at night? Classically, you know what they say? As they are eating, they're not able to complete the meal. They get tired. Okay. So one doctor made a diagnosis that the patient could eat sambar rice, could have the rasam rice, but when it came to curd rice, he could not swallow. That was one classical history that one doctor gave about the patient. That will be the presentation. Yes, not that it's there. Okay, in the morning he's able to have food, breakfast, he's able to have lunch, but in the evening he has difficulty in swallowing. Is it possible? All the questions, even I do not know, all the questions will be directed towards some of the physicians who are very good in general medicine. They will just probe you into myasthenia gravis.
Okay, madam.
Drooping of eyelids. When the patient knows about that drooping of eyelid, tremor or gait disturbance, that is for you to examine and tell.
Okay, madam.
I hope you're understanding.
I understood, madam. I understood.
Now, when will you ask for history of painful swallowing and vomiting? Why did you ask for history of painful swallowing in a patient who's got difficulty in swallowing for 3 months?
Madam, any odinosia conditions, any ulcerations of the mucosa, which causes the painful swallowing?
Give me 3 conditions or 2 conditions when you have a painful swallowing.
Madam, it can be infective or non-infective. Infective can be cytomegalovirus, herpes simplex virus. Non-infective, the most common killing condition is pili esophagitis, especially doxycycline.
So you know the theory, but do you think you can ask this particular patient this question?
Yes.
In a patient who is swallowing, any other thing, can this particular patient have a chest pain or a squeeze pain when he's swallowing?
Yes, madam. The patient may be associated with a distal esophageal spasm, achalasia. The patient will have chest pain.
Yeah, so in early achalasia, so difficulty in swallowing, they can have a chest pain, but it's not a painful swallow, but they'll have a severe chest pain when the act of swallowing takes place.
Yes, madam.
Okay, you mentioned about regurgitation. Now, regurgitation also, there was some question. What was it? was able to swallow food. Now all this, no, I don't know. The outpatient clinic will ask, you're able to chew, and then you masticate, and then you swallow. There's so much of description, normal chewing, which later he had to chew more number of times. So what is this chewing more number of times, less number of times? Supposing he's taking mashed curd rice, he does not have to chew at all. What I want to convey to you, doctor, in the exam, just remember that you're seeing the patient not for the exam. You're seeing the patient in an outpatient clinic. That's it.
Yes,
In an
ma'am.
outpatient clinic, simple questions. What is your problem? You can say, I'm not able to swallow, I'm not able to eat well. Then you ask, what is your problem? You say, when I'm able to swallow, the food gets stuck somewhere lower down. I need water to push the food down. Then you'll say, how long you're having this problem. Then you'll say, I have the problem for the last 3 months. Then you say, is it progressive that earlier you were able to take solid food, now you're having problem? That's all. Don't talk so much about chewing and mastication. 10 times earlier, now 4 times now. To me, it makes no sense as far as these questions are concerned. And then once you've got that history, that he has difficulty in swallowing for solids earlier and now for liquids, you'll be able to break the dysphagia towards the end. That's all that you have to highlight. And then you mention about the pain, mention about the regurgitation, mention about GI bleed, mention about secondary constipation. These are the things that you have to highlight. There's too much of a description of that chewing, no? Gradually, as examiners, we'll not even be hearing you. We just say, what is he chewing? Patient feels sticky, they have to chew more time before swallowing. Okay, so just be careful on that.
Yes, madam, I understood.
Now, regurgitation, most important is he able to complete the meal? That's all. In a patient with difficulty in swallowing, is he able to complete the meal is all that we need to know. So if he's not able to eat beyond 2 or 3 morsels of food bolus, then it tells you that, yes, it is getting stuck there. But if he's able to complete the meal, that means the problem is somewhere in the stomach.
Yes, madam. Yes, madam.
BT, I think, can you just elaborate and just inform about this?
Because in earlier descriptions, we have told, when you discuss the history, the negative history must be relevant to the case you are presenting, not the entire chapter of things which is given in Schlesinger on description of dysphagia. Okay, I know what you did. It's an elaborate description, but unfortunately, it is not relevant to the case. That's the issue. It has to be relevant to the case. The negative has to be relevant to the case. Okay, because each negative thing, remember that the examiner can stop you midway and ask you what is the relevance of your question. And you must be ready to. Okay, that's number one. Second, in the absence of a neurological history, like a stroke or some other relevant neurological problem, too much neurology detailing probably is not relevant to our case. Because Anup, you know the diagnosis of the case. You have the final diagnosis. So your history must be built around it and some relevant negatives. Okay, to give us a clue as to whether there's an oropharyngeal problem or it's an esophageal problem, whether it's a mechanical one or something else. Okay, but this much detailing, actually what will happening is that examiners will drift in their thought and they will come back and ask you again details. So never go into too much of elaboration. What ma'am said is absolutely right, and the negative should be absolutely relevant to the case. Okay.
Yes,
relevant to the case. Okay.
Shobana, you've joined? We continue?
We have joined. I'm listening. Give me 2 minutes. I'll put on my video.
Okay, fine. Okay.
Yeah.
Okay. Continue.
So I think I agree with Dr. Varghese Thomas that we have to be very, very relevant to the case. If you keep on talking about neurology, remember that many of your senior examiners know their neurology very well because they have done internal medicine in a lot more detail. You all jumped from medicine to gastro. They may have done a lot more medicine and they would know their neurology fairly well. And suddenly you will find yourself drifting into neurological dysphagia.
Absolutely.
So it's better not to touch upon too much. Whatever you have, just a few things are enough. Don't go into too much of detail.
Yes, madam.
Okay.
Yes,
okay,
madam.
continue.
Like what you mentioned about the choking, nasal regurgitation, change in voice, all is relevant. But then we may ask you, why did you ask all those questions? But that is relevant.
Yes, madam. I understand.
Okay.
Sabna, can we see you? Your video is off.
No, I have kept it off for a few minutes. I've just come home. That is
Okay,
why. Okay.
welcome,
Yeah.
welcome, ma'am. Because for
Okay.
most of our students from this side, this is your first official faculty assignment.
Yes.
So welcome, ma'am.
Okay.
We'll continue.
Just 2 minutes, I'll come back to you. Okay.
Okay, okay,
Yeah.
fine.
Okay. Chalo, bye.
Continue,
Shall we
doctor.
proceed?
Hello?
Yes, madam. Madam, there is no history of any change in difficulty in swallowing the hot, dark, cold substance. No history of any nocturnal cough, recurrent chest infections. No history of any change in difficulty in swallowing with any particular posture like relief with extension of neck or rising of hand above the shoulder. No history of regurgitation of food at night. No history of any globus sensation, halitosis, gargling, sound while swallowing, coughing of food debris. No history of upper GI bleed in the form of any blood in vomitus, passage of black colored stools. Shall I continue, madam?
Can you summarize everything what you have told in 2-3 sentences?
One more. Before.
The just now completed. Learn to say only relevant things, that too in a very brief way. Because, for example, no GI bleed is enough. Okay. Or we don't want no GI bleed. Okay.
Yes, madam. Yes, sir. 50-year-old male patient presented with...
Is it
Just
over?
a
Is it over? Is there
No,
anything
no,
else?
no.
Sorry, just a minute. Let
Two
me
more
go back
slides.
to...
Okay, Shobana,
No,
ma'am, say.
wait. Yeah, so one more thing is, see, you have in the beginning of your history itself, you mentioned that it was a progressive dysphagia which started with solids to liquids and went on progressing over a short period of time. And there was a significant weight loss. Now, mentally, you have already made your decision that this is going to be a mechanical dysphagia.
Yes, madam.
Okay. So don't again give too much points about motor dysphagia.
Motor dysphagia. Yes, madam.
Okay. So when you
Yes,
talk
ma'am.
about postures are
Yes,
very specific to motor dysphagias. When you
Yes,
talk
madam.
about regurgitation of night, that still remains relevant because in total dysphagia, you will still get regurgitation of night along with chest infections. That
Yes, madam.
remains. Hot and cold substances goes off. Globus sensation is not relevant here. This is not reflux. Halitosis may be there if there is a large amount of fluid sitting in the esophagus at night. Okay. Gurgling
Yes,
sound, coughing of food debris, all that is not really relevant here. That comes up with neurological dysphagias. And gurgling sound is more with Zenker's.
Yes, madam.
Upper GI bleed. How often do you see upper GI bleed in the CA esophagus? You will see anemia, but very rarely will there be this thing. So
Upper GI bleed.
yeah, so you can just say no history of bleed. Do not talk about details.
Yes, madam.
Okay, so
I
you
understood.
considerably shorten your history so that you have more time to discuss other relevant things. Okay.
Yes, madam. Yes, madam.
Next.
No history of any long-standing heartburn
There are some more no histories. Okay, continue.
or recurrent postprandial painful sensation in the biggest region. No history of any persistent hiccups, pain radiating the back. No history of cough and fever secondary to respiratory tract infection, yellowish discoloration of urine, abdominal pain, abdominal distension. Patient gives...
Why, doctor, why did you ask all that, doctor? Let's go back. Why did you ask all that? Why you look at the urine, abdominal distension? Why did you ask all the jaundice, abdominal pain?
Madam, if it is a malignancy, I wanted to rule out any medicine to the liver or ascites.
If that history was there, it would come as your chief complaint, no? That would have come as your chief complaint, no?
Yes, madam.
So would you ask in a patient, suppose you saw the patient at ascites, then of course that will come as a chief complaint, no?
I understood, madam.
Yeah, so now I'll just tell you, one is mechanical obstruction, 99.9% is mechanical. 1 minute, you listen now. It can be intraluminal. It can be in the wall, 1 minute, or it can be extramural. Okay, now you have to keep those three in your mind. Whatever you're discussing, is it intraluminal? I'm not certain you're dealing with CA esophagus. I'm thinking of something else. Or is it something actually intramural? Or is it extramural as a GIST tumor? Keep those in mind and give a negative history pertaining to that. For example, if a huge GIST tumor is extramural, they'll have chest discomfort. If it's intramural, that is something like a neomyoma. They may not have any symptoms except for some mild dysphagia. If it's intraluminal, then you ask for corrosive injuries, you might ask for food bolus impaction, you ask for mutton bolus impaction. These are the things that should come to your mind. And then mention antedating this, there was no history of acid, regurgitation, no history of acid peptic disease or heartburn. Keep that in your mind. Are you dealing with a web, a ring, or a Schatzky ring, number one? Or you're dealing with a neoplastic lesion that is present as intraluminal, intramural, or extramural. These will be your differentials as you discuss. I hope you're I hope you're understanding what I'm trying to convey.
I got it, madam. Yes,
Yeah,
madam.
so don't discuss of too many things about vasospasm of ions and urine and abdominal pain, distension. If that was there, you would have already got that in your history.
Yes, madam.
And no long-standing history of heartburn. If that was there, your history will be patient with history of GR for 10 years. No?
10 minutes.
Now then why do you want to mention that? In this particular patient, if you consider that possibility, then you say heartburn for 10 years, difficulty in swallowing for 6 months, and weight loss and loss of appetite for 2 weeks or something. Then you get the whole history of GR and get it.
Yes, madam.
I think both Shobna and I think just tell these students know how they should concise the history only towards the case. Even when you become a consultant, you will not be asking all these questions. You go straight bang on. Okay.
Do you have any relevant history, anything more?
Jason James, please switch off. Mute yourself. Jason James, please mute. You're disturbing.
Jason, please mute. For us, Jason James, please mute his audio. Okay. Now, okay, Anu, let him continue, ma'am.
Yeah.
Yes.
Yes.
Patient gives significant history of loss of weight of 18 kg in the past 3 months. There was associated with generalized fatigability and loss of appetite. For these above mentioned complaints, patient visited nearby hospital.
1 minute. Appetite loss will come first or the weight loss will come first? Weight
loss will come first.
And then you lose appetite.
Sorry, madam. Appetite loss will come first, followed by weight. In any obstruction, there can be, because of the obstruction, the patient will be taking decreased food.
Then the appetite will be normal.
Feeling of taking food will be normal, but the patient will be taking less food because of the obstruction.
Anyway, I already conveyed the message to you earlier. Don't bring in the two together.
In CA esophagus, how will be the appetite usually in the early case, not in the fag end with metastasis only.
Early case, the patient will have good appetite.
Good appetite. In fact, they want to eat and they are not able to eat. Okay, yes. That's it. Yes, and gradually, when the disease becomes too advanced, only the loss of appetite in CA esophagus. So, if there is a loss of appetite from the beginning, or even dysphagia and loss of appetite were too close, do you have any other differential diagnosis rather than CA esophagus?
Dysphagia.
See, usually in a CA esophagus, when the illness begins, appetite is well preserved, and gradually when the disease becomes too extensive, appetite is lost and patient lose weight and all those things. But from the beginning itself, if they have a significant loss of appetite and if the weight loss is out of proportion to diminished food intake, you have to suspect whether there is additional involvement of the stomach or whether the dysphagia is due to some systemic involvement like lymphoma or some other malignancy elsewhere. Extensive compression. Okay. So it may not be confined to esophagus at all. It may be elsewhere or esophagus plus stomach or extensive compression due to some other neoplasm on the esophagus. Okay. So if you have loss of appetite and significant weight loss, it cannot be a pure early CA esophagus. That you have to remember. Yes, ma'am. Shabina ma'am, you're ready?
Yes, I think what you're saying is absolutely right. Appetite comes first and then you go to this. And you can always ask him that when he started with dysphagia, did he also have a loss of appetite, or the loss of appetite is recent? That's also important. Okay.
Yes,
second,
yes,
so very important thing is sometimes patients are told the diagnosis and then they lose the appetite. okay, which is probably
Yes,
an
madam.
element of slight depression.
Psychiatric compounder.
Okay, but that is obvious. And when a person is told that he has a terminal condition, he's bound to lose his appetite. So always define since when he has lost his appetite, unless it was at the time that he started having. And when did he start having the generalized fatigability? That is something that you have to mention. Okay.
Yes, madam. Understood, madam.
The last bit, no, you mentioned what? Just go back. Now he went to a local doctor and was referred here, has no meaning.
Yes.
If something was done to him, at least you can say here an endoscopy. Now that particular sentence, he went to a nearby hospital and he was referred to this hospital. Just if you were to write a case report, that's how it has to be presented, okay?
Okay, madam.
Otherwise, you're wasting time telling them, yeah, he went to a nearby hospital and he was referred to this hospital. There's no meaning. I mean, this is the way I would analyze and give a crisp history, a crisp targeted history. That's how it should be, okay?
So then also, if the patient has gone to the hospital, taken 1 day of IV fluid and come to you, don't mention all that. Only if there is something done, like Dr. Jayanti said. Okay, now here in the past history, you put in corrosive at the end.
He's not spoken. Speak
Yeah.
out, speak
Okay,
out.
let him talk. Let him speak. Okay.
Past history of no history of any similar complaints in the past, no history of any hypertension, diabetes, bronchial asthma, pulmonary tuberculosis, ischemic heart disease, cerebrovascular accident, allergy, seizures, Parkinson disease, neurodegenerative disease, no history of any drug intake, no history of any prior foreign body removal, no history of any head and neck cancer in the past, no history of any corrosive injection in the past, history of no history of any radiation exposure, no history of any upper abdominal surgery, endoscopic procedures done prior. Personal history, mixed diet, appetite, reduced, unable to take food.
Wait. Shut up. They're not in a Shatabdi or we are not in a hurry.
We are not in a hurry.
We are not in a hurry at all. We will stop
Even though
here.
dysphagia is a short case, we are going to have a long case discussion.
We will not be discussing or because no histories. No histories are more than what is the present history. No?
Correct. You have mentioned no. First of all, you have mentioned no about 6 or 7 times in this history. Okay.
It's
Now,
monotonous.
the relevant ones. So you have a patient who is, how old is the patient? I missed that at the beginning.
53.
53. So what are the relevant things in this? No history of similar complaints in the past. So then the examiner will be tempted to ask you, tell me conditions where similar histories occur.
Answer now.
Now you answer. And we'll ask you about every negative history that you have given.
Madam, any esophageal ring or web which causes any food impaction at that time, any dysphagia, but the patient won't present like a 3-month history.
And history should have been, there is no prior history of food impaction. That's it.
Yes, sir.
That's
Okay,
all.
so is that relevant in this case? Tell me. What are the causes of food impaction?
Madam, either can be due to a stricture or a ring in which or a malignancy.
1 minute, wait. Which stricture causes food impaction?
Madam, it can be a peptic stricture or a malignant stricture or a foreign body stricture or a pill.
Foreign body stricture. What is that? What is a foreign body stricture? What is a foreign body stricture?
Okay, we can ask the other people also. Manmohan, what are the causes of food impaction?
Sir, again, benign, and you can think of benign and malignant. Sir. In benign, it can be due to peptic stricture, corrosive ingestion, then due to pill-induced ulcers, yield ulcers causing stricture. Sir. In malignant, we can think of CA esophagus, sir, carcinoma esophagus.
Without any stricture, can you get impaction?
Schatzki's ring, sir. In case of Schatzki's ring, also
That is a stricture. What are the causes of food impaction without any obvious strictures?
Those are neuromuscular causes.
Eosinophilic esophagitis.
Eosinophilic esophagitis. We are waiting for it. Somebody put it.
Okay. So you have to ask for relevant things. This patient, you have already thought that this is not a neurological dysphagia. So putting in CVA, And now you mixed up, ischemic heart disease is followed by CVA. Then there is allergy, seizures. So there is no order to what you have written. Now here, if there is a positive history, it makes a difference. A negative history has absolutely no value. What do you mean by no history of drug intake?
Madam, I actually wanted to any long-term history of
So
drug.
you have not mentioned long term. Which drug are you thinking of when you talk of this patient who has progressive dysphagia? Progressive dysphagia since 3 months with weight loss of 18 kilos. Which drug are you thinking of? Name a
If there
drug.
is a chemotherapy, Anup, that will be the dominant past history, no? Nobody will get chemotherapy secretly. So there will be a major illness, then only chemotherapy will be given. It is not a standalone business.
Absolutely.
So if you ask, tell us no history of drug intake, remember the next question will be, what are the drugs you thought of? The next automatic question can be like this.
Or what did you ask? Which drugs did you ask?
Okay, now you tell us which drugs. For the benefit of everyone.
I request all the participants not to put answers on the chat box, please. Just hold on, keep it, write it in your notes, and then as we're discussing, we'll come out. Okay?
Bisphosphonates.
So what is the kind of dysphagia that bisphosphonates give?
Mainly odynophagia with.
So it's a pilisophagitis, right?
Yes, madam.
So there is a sudden onset dysphagia with pain. They often give patients GRD symptoms, right? And rarely there can be strictures.
Strictures, yes, madam.
If it is long-standing, then there can be food impaction, or because of that small stricture, the patient will have mild dysphagia. They never go to a stage, or rather hardly ever go to a stage where there is total dysphagia and there is weight loss. Okay, yes, what do you mean by no prior foreign body removal?
Madam, any transmural injury of the foreign body cause a stricture.
How often have you seen this? Okay, in your 2.5 to 3 years in gastroenterology, how many CA esophagus have you seen? So think of that. How many CA esophagus have you seen?
Maybe 50 to 60.
52. How many of them had foreign bodies in the past?
Foreign body, I saw 3 to 4 cases sudden impaction of foreign body.
No. Foreign body, CA esophagus coming with food impaction is known.
Yes, madam.
Okay, if there is a partial stricture, patient has a large bolus, it will get stuck. We are talking about past history of foreign body removal. If the patient has foreign body impaction now, I can understand this is part of the disease. But if the patient had previous foreign body removal, when you meet my foreign body, you mean foreign body, or do you mean a food impact foreign body? So don't make such statements. No history of any head neck cancer in the past. In your 50 cases of CA esophagus, how many had head neck cancers?
Very rare only, madam.
What is the prevalence of concomitant or sequential head neck cancers with CA esophagus?
Less than 5%.
5% is a very big number, sir. 1 in 20. 5% means 1 in 20. So in your 50 patient series, you should have seen at least 2. Is that correct? Not correct?
Not correct, madam. I haven't seen.
So how many did you see? So, when you put up this whole thing, think of the 50 cases that you saw in the wards, and you will automatically decrease your negative history also.
Yes, madam.
Okay, but now answer this question. How often is head neck cancer associated with CA esophagus?
Less than 1%.
You will read up and tell us.
Yes, madam.
Okay. Next. So, no history of corrosive ingestion and past history of radiation exposure. Right?
Yes, madam.
Yes. So, again, in case of radiation exposure, if it is there, you mention it. If it is not there, don't put your foot into it.
And radiation exposure where? In the pelvis?
No, madam.
Pardon?
Mediastinum, madam. Mediastinum, head and neck radiation exposure.
So what are the causes of radiation that will cause an esophageal stricture, which will cause a progressive dysphagia?
Radiation-induced esophagitis, radiation stricture.
Yeah, so what is the natural history of radiation esophagitis?
It can occur at any time after radiation, maybe after long duration of radiation with a past history, the patient can present with the radiation esophagitis.
Is it? Or initially they present with odynophagia and dysphagia?
Ramya or Manmohan, do you want to answer? Ramya is there?
Yes, sir.
Okay. You heard Shobana ma'am's question, no? What are the ways in which radiation injury to esophagus presents?
A stricture in the upper esophagus.
That is one of the methods.
Which,
Can you say this serially or as it evolves? Manmohan, can you offer? Do you know?
It will take a little longer duration, sir, more than 2 to 3 months, or it's more than 6 months after the radiation for the stricture to develop. Radiation-induced stricture, esophageal stricture can be developed.
anyone has better answers on this?
I think only 3 are online. All the others are listening mode only.
Okay, fine. So radiation esophagitis usually starts off with odynophagia, severe pain, and they decrease their intake. And eventually they can develop strictures, but this kind of complete strictures with progressive damage is a little less, and they would be tackled beforehand. What are the causes of which malignancies get radiated that the patient gets an esophageal stricture?
Madam, it can be mediastinal nodes, any CA breast, then head and neck malignancies.
1 minute.
The chest, first finish chest.
Just CA
breast,
breast.
1 minute. CA breast, I thought they don't get deep radiations. Only if there are lymph nodes they get.
Earlier period when there was not focal radiation.
So you think many places in India, they still have this old series of radiations? No.
No, madam. No, madam.
No. So
What are the
media-
malignancies in the chest for which a radiation can be given? What are the
CA
malignancies
is,
in the head and neck?
CA lens, then mediastinal malignancy, then head and neck malignancies. Lympho.
okay, I think you move on, Dr. Anup.
Fourth child of a non-consanguineous marriage, no history of any malignancies in the family. Nutritional history, calorie 2,400 kilocalorie, protein 54 gram, intake 1,000 calorie, protein 24 gram.
So what does this mean? This does not make sense. This is not making any sense, this line. And also
This,
look at the
this-
previous line.
This
Which
finding of family history, fourth of a non-consanguineous marriage, what has that got to do with this particular patient?
What relevance does it have?
Got
No,
no relevance to this particular case. I think
No
we have to just pull up them on the history taking. Theory, they'll answer when.
Yeah. What is the history of malignancy that you asked for in the family? Suppose the brother had CA prostate, is it relevant?
No, madam. Any
Suppose the
head
mother
and neck.
had CA breast, is it relevant? No, so what malignancy did you ask and which family members did you ask for? Brothers, sisters, parents, cousins, uncles, aunts. Whom did you ask?
Madam,
Just random, no history of malignancy in the family. This is what happens.
any history of any head and neck malignancy, any history of any gastrointestinal malignancy, any
Which
polyposis,
gastrointestinal malignancy?
any adenomatous polyposis.
Do you think
No.
adenomatous polyposis of the colon is related to esophageal malignancy in this patient?
No, madam.
See, Anup, we have to be very clear. The malignancies you mentioned has to have some bearing on CA esophagus. We are suspecting CA esophagus or maximum CA fundus. Okay, so there should be predisposition in the family in such a way that they have some related cancers. So like in a cancer family syndrome, whether they have cancers elsewhere, whether it can produce esophageal cancer. So how often you find esophageal cancers associated with the other tumors? That's a question. Okay. See, by just saying that, you are inviting another question.
Yes, sir.
And we haven't
Manmohan,
even finished the
is it
history.
possible? How often you find?
Sir, I don't know, sir.
You don't.
I think CA esophagus got less association compared to other tumors. That's what I understand. Chavanama, am I right?
Yes, I'm right. Yes, you are right, sir. So the only thing you should be asking for is which CA esophagus runs in families?
CA esophagus.
Anything to do with the palmar and the plantar region?
Any
Tylosis,
genetic syndromes?
tylosis of palm.
Right.
Palmar plantar tylosis.
Tylosis.
Basic,
So-
basic syndrome. Basics.
No, finish this and then go. Okay.
Yes.
So palmar plantar
Tylosis.
tylosis. So what is the age of presentation in these patients for CA esophagus?
Younger age group.
Younger means 10, 25. Don't give such random answers.
I don't know,
Okay.
madam.
You don't. Okay. Now come to nutritional history.
Yes, madam.
Tell me, what
Calorie-
does this sentence mean? It does not make any sense to me.
The patient is taking decreased food because of dysphagia. He's only having liquid diet.
No. Calorie to 2,400 cal, protein 54. Then you are at intake 1,000 cal, protein 24. Is it the ideal requirement for his age and weight you have mentioned? And what
Yes,
he takes?
ideal is 2,454 gram protein. Only intake is 1,024.
So is that clear from this sentence? No. What you have to
Okay.
actually tell us is pre-morbid, what was his calorie intake? And currently,
madam.
what is his calorie intake?
Yes, madam. I understood, madam.
You understood? We are not
I
interested in ideal for him. No, we want to know what was his pre-morbid calorie intake, which was keeping his weight constant. And now how much is the calorie intake and protein?
It's able to take. Yes, madam.
Okay. And
Yes, madam.
okay.
Okay.
Shall I go?
Next one.
50-year-old male patient presented with the history of painless progressive dysphagia, probably lower esophageal dysphagia, grade 2, mainly for solids and semi-solids associated with
Summary, you do have
Why
to, we
is
have to
lower
say
esophageal?
probably lower esophageal. Because summary
no,
is
sir.
just a summary of the history. You don't interject any inference there, no?
Yes, sir.
Okay, and
50
even
years-
Saeed and all those things. Okay, continue, please.
50-year-old male patient presented with painless progressive dysphagia, mainly to solids and semi-solids associated with a significant weight loss without any neurological manifestations, recurrent chest infection, UGA bleed with no comorbidities and ECOG performance status of 2.
What all thing can be actually deleted from here without the negative ones?
Grade of dysphagia, lower esophageal dysphagia.
Well, significant you can say. Whether it evolved over the period, a short period of time gives us some idea as to what illness it is. Evolution of the illness over a short period of time gives us some idea. So severity you can mention. And I think we have, again, you have mentioned so many negatives, no? Unless those negatives are very relevant to the case, there is no need, no?
And,
Yes, sir.
and this probably lower esophageal. What is that? Probably lower esophageal.
Madam,
What
actually,
is that probably lower esophageal?
The lower esophageal, the patient recognition will be somewhat less compared to patient recognition in the upper esophageal. He is telling like something
What is
stuck
it?
in the patient won't be able to localize properly compared to upper esophagus in case of lower esophagus. The
Don't mention
patient
all
is,
this. They will say that you
what
know
is
the
this?
case. They will say that you know the patient, you know the case.
okay,
Huh?
madam. Yes,
Yeah,
madam.
So what lower esophageal what? Growth, what is it? Probably lower esophageal what? What? Lower esophageal what?
Probably he wanted to say the location, but I think it's a far-fetched
No,
and
growth,
you should not do that.
Right now, you don't know.
You should not do that because that is dangerous. First, it's an inference which is not required. Second, the examiners will feel that you got a clue already.
no other thing, the reaching the progressive dysphagia, probably low dysphagia is through and through the esophagus. What is lower esophageal, upper esophageal? Unless you want to say lower esophageal growth or something like that. Dysphagia is uniform, no? It's uniform throughout. The swallow reflexes throughout. How do you say it's probably lower esophageal? It's not lower.
What?
Dysphagia
It's not lower
cannot.
esophageal. So
Yeah,
you have
dysphagia.
just-
Dysphagia cannot be lower esophageal.
Oh, understood, madam.
So you have to say localized to which part of the thing, whether it is localized to the mid-sternal region or the lower sternal region. Okay, you could say that where it is localized. Now, when you say progressive, it means that it has progressed from one thing to another. So when you say there is dysphagia
yes,
for solids and semi-solids, you have to now mention whether it has progressed, what is the current things that he can have. So what are the things he can have now?
The patient is able to swallow liquids, madam.
So that's right. So progressive dysphagia to a state where he can only swallow liquids now. Dysphagia for solids and semi-solids is not relevant. He can no longer have dissolids. So you have to mention painless progressive dysphagia to a stage where he cannot even swallow his saliva,
Okay, madam.
associated with significant weight loss.
Weight loss.
Neurological deficit is not really relevant here. I
Yes,
would
madam.
have been happy to hear whether the patient has change in voice,
Yes, madam. No change in voice, madam.
chest pain, upper GI bleed. Again, I told you in the beginning, only if it is there, you talk about it. Recurrent chest infections, instead of that, mention cough.
Yes, madam.
If there is no cough, it's less likely to go into recurrent chest infections unless the patient has a neurological problem. Which comorbidities are you talking about?
Madam,
I know when you say about recurrent chest infection, what is in your mind? What do you want to rule out?
sir, two things: either because of any aspiration pneumonia, because of any achalasia, or obstruction itself causing aspiration.
Is the history suggestive of achalasia?
No,
This
no,
is
no.
summary. Summary
No,
has
no,
to be absolutely relevant negative only, not the entire list of negative. Is the
Yes, sir.
history of suggestive of achalasia?
No, sir. No, sir. No, sir.
Okay. So one is okay in stricture in achalasia we can have stasis and then aspiration respiratory tract infection. Is there any way by suppose we are suspecting neoplasm? Is there any way which you can think of infection?
Sir, one can be any tracheoesophageal fistula. Two can be any because of complete obstruction. Microaspirations can also occur.
Okay. Over to ma'am, Savna ma'am.
So no, so that's correct. There's hardly anything to suggest achalasia here. Okay. So when you talk
Yes, ma'am.
about recurrent chest infections, you're talking about aspiration, usually from neurological, but sometimes upper esophageal lesions when there's a lot of fluid collected, it can cause. So it's better to say cough.
Yes,
The
ma'am.
second thing is there could be a tracheoesophageal fistula, and there can be cough during swallowing. That should have come in your history. If it has not come in your history, do not talk about these negatives here.
Yes, madam.
Okay. And which comorbidity are we talking about?
Madam, I mentioned like generally the patient doesn't have any comorbidities like
But which
hypertension.
one?
Who's speaking? Sorry.
No, I know here again, if somebody has a comorbidity like diabetes, hypertension, etc., you mentioned. But once you have mentioned in the past history, these things are not there, don't again bring these things into the summary. Because summary has
Okay,
to
sir.
be concise, to the point. Positive history plus absolutely relevant negative history only. Okay.
Yes, sir.
Don't bring in too many unnecessary things, because each of these unnecessary things you can invite questions and go away from your case, and probably you will not get the merit of being examined properly.
Yes, sir.
Can you rephrase your summary once again?
Yes, sir. 50-year-old male patient presented with a history of painless progressive difficulty in swallowing, mainly for semi-solids, solids and semi-solids. And now the patient is able to take liquids only, with a history of significant weight loss without any cough.
In the history, you have said anorexia also, no? Now it is missing. So the significant anorexia and weight loss.
Anorexia without any significant, without any cough, UGA bleed, or chest infections.
Cough is enough, and without any significant neurology symptom. Okay. I think that would be enough, no, ma'am. Because
Yes,
again, telling too many negatives in the summary also irrelevant.
Because it tends to, kind of put the attention of the examiners on the negative history, and immediately they will ask you questions as to why you have asked this history. Okay?
Yes, madam. I understood, madam.
Okay. You can write these down on your paper, which will, if the examiner asks you, you can say, sir, I have taken these histories, but
Yes,
in order to make the history more concise, I have not mentioned them, which is also accepted. It's there in your papers. Okay?
Absolutely, yeah. That's perfect. Yeah.
Yes, madam. Understood, madam.
So what's your syndromic?
Madam, painless progressive dysphagia grade 2, secondary to intraluminal obstruction of esophagus.
No. What is your syndromic diagnosis? Syndromic. Don't describe the history again.
Madam, painless progressive dysphagia, secondary to intraluminal obstruction, probably malignant, without any tracheoesophageal fistula.
How can you be so sure? No tracheoesophageal fistula.
You can only talk of things which are there. You
Present.
things which are not there.
Yes, madam.
What are the components, doctor, of syndromic diagnosis? So one is dysphagia, no? What the patient has is a progressive.
Any risk factor like smoking, tobacco, alcohol?
Smoking is there.
Then, so risk factors come there, only very, very relevant negative histories. You can't repeat everything here. You just.
Yes, madam.
So what
Okay,
is
I know you have to tell us from this history whether it is a motor dysphagia, mechanical dysphagia, and the etiology.
Sir, painless progressive dysphagia, mechanical, secondary to intraluminal obstruction of esophagus, with the smoking as a risk factor.
Intraluminal obstruction, again, tell us what is likely etiology.
Probably malignant. With the comorbidity.
Which malignancy you are considering? Carcinoma or leiomyoma or leiomyosarcoma? Because you are said only malignancy, no? I can think anywhere.
Or a disc tumor.
Malignancy and most likely.
Most probably.
Neoplastic, mechanical, so you say progressive dysphagia, mechanical obstruction, most likely intraluminal, but you'd like to consider, 1 minute, you'd like to consider extraluminal as well, as a possibility. You have to consider this possibility, complicated by severe anorexia and weight loss with a performance scale of 2.
What is the explanation for anorexia weight loss?
Sir, weight loss because of decreased food intake because of the dysphagia.
But it occurred along with the onset, no? Because everything was 3 months duration, no?
Yes, sir. Actually,
that was a red herring in your story. That is, anorexia and weight loss occurred almost along with the dysphagia, which is unusual. Jayanti ma'am was catching on that. The first
ma'am.
sentence in the history. Usually it is not seen in CA esophagus. So if you find anorexia, weight loss significant to begin with, you have to think of something else. So what else you will consider?
Any lymphomas, sir.
Lymphoma where?
Lymphoma of the mediastinum causing obstruction along with the extraluminal obstruction lymphomas. And
Can you think of something else which is more likely? Okay, then Manmohan, do you want to consider anything else?
What are the causes of mediastinal lymph nodes that can cause dysphagia?
tuberculosis, sir. Tuberculosis.
Lymph nodes can be due to many causes, Anup. Enumerate. Madam asked you what are the causes of enlarged lymph nodes causing mediastinal, no? So you have to answer only to tuberculosis. There are many empty number of other causes. What are those?
Okay.
Manmohan?
Yes, sir. It can be again. Mediastinal lymphadenopathy can be divided into infective and non-infective. In infective, it can be due to tuberculosis. Then it can be due to other things such as sarcoidosis, other infections such as sarcoidosis. Then it can be due to histoplasmosis. Then lymphoma, sir.
Neoplasms, no.
Neoplasms such as
Lymphoma, carcinoma, esophagus, no.
Everything.
Yes,
Yeah, but what you have to remember is somebody comes with progressive dysphagia and severe weight loss. The lymph nodes which can actually not only compress the esophagus, but also involve the esophageal wall are usually tuberculosis and lymphoma. The rest of them like sarcoidosis, histoplasmosis, they will not enlarge so much as to involve the wall of the esophagus. Tuberculosis, the lymph nodes which have caseation can actually rupture into the esophagus and give rise to severe dysphagia. They can give rise to sinuses and fistula there. So therefore, tuberculosis is relevant. Okay, lymphoma is relevant, but the others, yes, there are large lymph nodes. Giving rise to mild dysphagia is known, but that is because like an extrinsic compression. But definitely for someone to have progressive dysphagia to the point that he can only swallow his own saliva does not happen with pure lymphadenopathy.
Yes, madam.
Okay.
Yes, madam.
And one question, Mohan, you are asked a question. What do you think of the possibility of dysphagia, anorexia, weight loss? Do you want to offer anything, or do you still stick on the esophageal carcinoma?
Esophageal carcinoma first, sir. Then other thing can be G junction carcinoma. Then I would also like to consider CA stomach, sir, in malignancy.
No, you have to say carcinoma stomach affecting the fundus involving the G junction. Or primarily G junction neoplasm. A pure small G junction neoplasm, will it produce this much anorexia, weight loss?
Okay.
Because G junction neoplasms are notoriously known to present much early, because that area is normally a sphincter, is the most narrow area, and once it is affected, they will have symptoms quite early, you know. It won't, the patient won't wait till they have anorexia, weight loss. Stomach malignancy, perhaps, if it is not affecting the cardia, but the fundus, they may still present with anorexia, weight loss. Okay. It may. Okay. So, Ramya, do you have any thoughts?
No, sir.
Okay. Now, Shobhana ma'am, there's a huge list of differential diagnosis put up there.
Going through them. I was just going through them.
Your comment on that, because it is, I think it will be too dangerous to say totally unrelated issues. We consider mechanical dysphagia and suddenly there is achalasia coming. Okay.
Achalasia is coming, esophagitis is coming. See, again, Anup, remember, think of your 50 cases. Think of your 50 cases.
Yes, madam.
And look at the severe dysphagias that came to the hospital for 3 months. Your etiology is going to be an intraluminal lesion in the esophagus, Very occasionally, it can be in the wall of the esophagus, which is causing dysphagia of this degree. So, which are the causes which can progress to this level? So, esophageal malignancy is correct.
Yes,
Whether it
madam.
is squamous, adenomatous, we are not arguing right now.
Yes, madam.
Okay. What is
Yes,
the
madam.
characteristic of peptic strictures in terms of dysphagia?
Peptic stricture, usually the patient will have a long-standing history of GERD, followed by dysphagia, mainly to the solids.
No, they can even have dysphagia to liquids.
Liquids
They can
also.
even have worsening dysphagia. But what is the main thing? What is the main thing that differentiates esophageal cancer from peptic stricture? Is weight loss.
Weight loss.
Okay. They usually don't lose as much weight as an esophageal cancer.
Yes, madam.
Okay.
Yes,
Next,
madam.
external compression. I just mentioned that when there are lymph nodes in the mediastinum, yes, there can be dysphagia, but it does not progress to the level that this patient has.
Yes, madam.
Okay.
Yes, madam. Yes,
Any
madam.
lymphoma will also have weight loss. Any lymphoma may have chest pain. They will have other lymph nodes. They will have systemic
Fever.
symptoms. Fever. Okay. Achalasia is completely a surprise here.
Yes, madam.
Okay. Again, if the patient had achalasia and has esophageal cancer now, the chances that he will have dysphagia is only when the patient has a very late disease, because achalasia is associated with dilatation. The lumen doesn't get compromised. So achalasia is not something to be mentioned. Why esophagitis? Why have you mentioned esophagitis? Which esophagitis are you thinking of?
Eosinophilic esophagitis.
Progressive
You're treading
dysphagia.
into a dangerous path, Be very careful.
Correct.
Okay, now the immediate question will be what will be the usual history of dysphagia in eosinophilic esophagitis?
Correct.
Usually the patient will be having any atopic symptoms with the...
No, I specifically, what is the usual history of dysphagia? That is what I asked.
Yeah, the patient usually will be having non-progressive intermittent dysphagia with the...
Intermittent, non-progressive. It may progress subsequently, set up stricture, but intermittent to begin with at least.
Yes,
that
sir.
is it.
Yes, sir.
It is intermittent and it is associated with food impaction.
GERD symptoms, food impaction.
Maybe GERD symptoms, yes.
Yes,
okay. What about GIST?
You have put GIST and leiomyoma, one below
the difference
the other. Among these two, which is more likely?
GIST is more.
What is the difference between GIST and leiomyoma?
We can just put in a big list and all the conditions. Among GIST and leiomyoma, which is more common in the esophagus? Okay. Two questions are pending. Shamyama asked what is the difference between GIST and leiomyoma, and I asked a question: what is the most common, which is more common, GIST or leiomyoma in the esophagus? Manmohan?
The leiomyoma is more common than GIST in esophagus.
Yeah, remember, leiomyoma both may look morphologically same, and only when you take perhaps FNAB, you will be able to make a correct diagnosis. But leiomyoma is much more common in esophagus when compared to GIST. Okay, it's mostly leiomyoma, and only very small percentage is the classical GIST where there is no origin from muscular tissue. Okay. Lymphoma, already mentioned it. One thing, again, the cancer is rarely some person with a CA lung also can have large mass lesion in the esophagus, which may produce compression, and sometimes it may even erode into the esophagus, very rarely. So, CA esophagus, lymphoma, CA lung. These are the three which can produce dysphagia from the malignant side. Then lymph nodes due to tuberculosis. Manmohan mentioned the sarcoidosis, but sarcoidosis seldom, it may produce some effect on barium solo, but the significant dysphagia like this is very unusual.
Okay.
Okay. Yeah. Shamyama is temporarily not available, but I think, do you have any other differential diagnosis, Manmohan?
No, sir.
Okay. Ramya, do you have any differential diagnosis?
No, sir.
Okay, now physical findings. We'll go to physical findings.
The patient is conscious oriented, moderately built and poorly nourished.
What
lying
did he
comfortably-
shortlist? PT? Shortlisting? What are the differentials? Shortlisting?
Shortlisting is CA esophagus.
Carcinoma G junction.
Hmm?
CA esophagus.
Okay, you please tell. Okay.
Carcinoma
First
esophagus.
priority.
First priority carcinoma esophagus. Second one carcinoma G junction. Third one external compression. Fourth one peptic stricture
External compression due to what?
due to lymphoma or tuberculosis.
Okay.
Tuberculosis nodes per se would not cause it to be cold abscess or something like that, no?
Yeah,
Usually
with the abscess formation and perhaps
pot spine or something like that.
Okay.
Normally, nodes will not cause. What about fundus of the stomach? Fundy growth?
Yes, madam. Fundic growth infiltrating into the G junction.
No. Would you consider the possibility?
Yes, madam. Yes, madam.
I would say that in spite of my prompting many times, it was difficult to get the diagnosis from all the three persons. I think if anorexia weight loss is dominant, you have to always consider fundus. That's my
So, yeah, what will be the presentation of a fundy growth?
Madam, the fundus growth, the patient will be more present with anemia rather than dysphagia. Later on, the patient will present with dysphagia.
No, anorexia,
Anorexia and weight
and
loss,
then
anorexia,
Early-
weight loss, everything
Plus
is there for 3
anemia.
months.
Early satiety will be done.
The patient has got anorexia, weight loss, it's for 3 months.
What
It
else?
is not
What else will the fundus? What else will a fundus growth present with?
Early satiety, ma'am. Ready with that.
Early satiety. Okay, then
Anemia.
early satiety because the fundus is failing to accommodate.
Yeah.
You said anemia, you said weight loss, maybe anorexia. So sometimes fundic growths which are very close to the diaphragm, we can keep irritating the diaphragm, the patient will come with hiccups.
Hiccups.
So one of those unusual symptoms of gastroesophageal malignancies is hiccups when the diaphragm starts getting involved.
Hiccups, recurrent hiccups.
Okay, yeah.
Yes, madam.
And at times pain at the back, radiating to the back.
Yes, pain at the back, yes.
Infiltration into the neuron plexus.
Okay.
Come on,
physical
move on.
findings, please.
Relevant
Now-
findings.
Relevant only. Only tell us the positive.
Pallor is present.
Okay.
No supraclavicular lymph node enlargement. BMI is 16.55.
Next slide. Tell only positive things. Is there anything positive on general examination, on examination of the abdomen?
Nothing, sir.
How would
So,
you,
what are the relevant
look for,
findings?
how would you look for sympathetic involvement? What are the signs for a sympathetic nerve involvement in CA-2, this mediastinum? What are the eye signs?
There will be Horner syndrome, madam.
Who will mention that? You have to mention, no? Because you mentioned so much about voice change, tone of voicing change. So you have to mention all that. What is the importance of examining the oral cavity in this patient?
Madam, oral cavity from the oral.
First, foremost, faces. Tell me about the faces.
Yes, madam. From the oral cavity, there will be decreased
Faces. What is, as you see the patient, can you make a diagnosis of dysphagia? What are the conditions?
From the face.
Just the face, as you see the face. Just you see the face.
Person walks into your clinic,
And you
look
make
at
a
the
spot.
face and you say this patient is likely to have dysphagia.
Tell the faces, yeah.
um,
Manmohan, Ramya.
Patient is having facial nerve palsy.
No.
Facial nerve palsy will not be that significant dysphagia now.
Facial nerve palsy
Drooling,
will not
no?
have dysphagia.
Rolling of the saliva.
Baba, dysphagia, we're asking
If
for
it is a
dysphagia.
stroke, they will have difficulty in walking also. So that is not on the face. No?
Somebody has said Parkinson's face. We are not looking at neurological dysphagia. We are looking at
Decreased opening of mouth.
dysphagia. Somebody said sarcoid faces, muscular dystrophy. No, we are not looking at neurological or neuromuscular causes.
decreased opening of mouth.
Esophageal cause. What is SSC now? I don't know what that is. For me, it is the degree I got after passing 11th standard. What is ptosis? What has ptosis to do with this? We're looking for esophageal dysphagia.
Mechanical.
Anybody wants to think of scleroderma?
Scleroderma.
Decreased opening of mouth. Decreased opening of mouth.
Are Baba, scleroderma. What is scleroderma facies? Yeah.
Yes,
How
madam.
will it appear?
Systemic
That,
sclerosis.
the pinched up nose with the decreased opening of mouth and decreased stretching of skin.
Can you recognize that when the patient walks into your OPD?
Yes, madam. Yes, madam.
Yes. So that is what you have to talk about.
Yes,
Okay.
madam. Then in the oral cavity, the oral mucosa, any submucosal fibrosis, the tongue, any atrophy of the tongue, then the
What is
position of
causes of submucosal fibrosis with relevance to dysphagia?
generalized retroperitoneal fibrosis.
Retroperitoneal. We're talking about submucosal. With relevance to this case.
OSMF.
So what is this? Patients who have Gutka, they tend to develop, yeah, I think somebody's answered tobacco intake. Patients who have Gutka tend to have submucosal fibrosis.
Fibrosis.
If you can recognize that, then the patient
ma'am.
cannot open his mouth.
Yes, madam.
So just to take so questions here, they've asked for oropharyngeal, especially in patients with say barium swallow showing high stricture. Please read all the cranial nerves. Which are the cranial nerves that are involved in swallow reflex? These are common questions in the DNB exam.
5-7.
1 minute, you don't answer here. I'm just telling you the questions. This is mechanical, but I'm just telling you, these are the questions that are asked. Which
Yes,
portions of the brain, what is swallow reflex? What are the centers of, just listen, what is swallow reflex? What are the centers involved? Which are the cranial nerves involved? And therefore, which are the cranial nerves you'll examine and how do you examine? These are all DNB Viva questions that are being asked in the exam. Okay, this is an offshoot of what we're discussing, but please read all. Okay,
Yes, ma'am.
continue.
Next slide. Nothing positive, no?
Yes, madam. Yes, sir. Nothing positive, sir.
Okay, so after
What,
physical
1 minute, what are the cutaneous markers you look for in this patient?
Yes, 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 madam. The
Yes,
patient,
madam, what you tell us
I
the
will
important.
tell madam, there is no tylosis, no lesser sign of triad, no Palmer and hyperkeratosis,
That is
acanthosis nigricans, acanthosis nigricans.
Acanthosis nigricans, how it is relevant?
Esophageal malignancy.
here lung, okay, but here esophagus, how often you find it?
And what is that? No, dilated veins, scars, sinuses. What is that? What is
Any
this?
metastasis.
But by dilated veins.
Dilated veins, scars, and sinuses where?
Where?
I know once you have targeted, once you have sort of shortlisted your DD from history, then onwards you have to be, your presentation has to be little more sort of edited. Don't put the entire negative dilated veins, hernia, hydrocele, and all those things. Now it has to be highly relevant. Okay,
Yes.
I found external genitalia also you have mentioned. It's a part of complete examination, but in this case, usually dysphagia is given as a short case. You won't have this much luxury of examining in great detail. You don't have that much time, etc., etc. Okay, so it has to be very relevant.
Yes, sir.
So you have to talk about the oral cavity. You have to talk about the lymph nodes.
Yes, sir.
Talk about liver palpable or not palpable.
Yes, sir. Yes, madam.
Any other lump in the abdomen. Okay. Those are
Yes,
the main relevant things. Then you ask a patient whether they have any backache. What are the common sites of esophageal CA spread?
Madam, it can spread to lungs, liver, brain. It can infiltrate to the surrounding tissues. Can spread to pleura, pericardium, diaphragm. Infiltrate towards the nerves, causing back pain also.
So that's why you have to know all this, no? If you know where it is going to infiltrate, accordingly, you will give your findings. Because esophagus per se will not give you anything for examination. You cannot examine the esophagus, no?
Yes, madam.
Locally. right? So therefore,
madam.
you have to look for the places where it is visible, and only those relevant examinations you have to give.
Yes, madam.
Okay, if you start everything, head and neck, no palpable mass means what? What did you look for?
Madam, any thyroid swelling, thyroid swelling, and also any lymph
How
nodes.
often is thyromegaly associated with CA esophagus?
Thyroid swelling, huge thyroid can cause compression of esophagus and cause dysphagia.
But did you think of
CA
because that
esophagus,
means you are
not,
giving us
no,
1 minute?
madam.
I know that means you are giving us a new differential diagnosis here. You are saying that thyromegaly causing compression to give dysphagia. You are giving us one more differential diagnosis here, which you
Okay,
did not talk about in your case.
Yes, madam.
So
And
what
retrosternal thyroid enlargement
Yes,
produce
retrosternal thyroid
dysphagia.
also. Yes, sir.
did
Which
give
part,
rise to
which
this
mediastinum
kind of
it is?
dysphagia?
Which mediastinum it is located? That's not a clinical picture. What about thymoma? Can it produce dysphagia? See, this was a catchy traps.
Correct.
Okay, because these the retrosternal goiter and thymomas are not situated in the posterior mediastinum.
Correct.
Okay, so
Anterior mediastinum only.
so it will not produce dysphagia in the, unless it's a very huge one, which is extremely unusual. Normally, in the normal clinical scenario, it doesn't produce. Okay.
Sir,
I
this
think in the
is
interest
very-
of time, we will proceed.
Summer-Wilson syndrome. Okay, right. We'll come to that later. Yeah.
Okay, proceed. So you have finished physical findings. So physical finding positive was low BMI and
and pallor. Pallor.
mild pallor. Other than that, everything is negative.
No
Yes,
lymph nodes is relevant. Okay, now just a
yes.
little theory question. Which lymph nodes does the esophagus cancer spread to?
Madam, the upper one third of esophagus, the lymph nodes drain into deep cervical nodes and then to the thoracic duct. Middle one third of esophagus, it drain into the superior and posterior thoracic nodes. Lower one third of esophagus drain into left gastric and celiac nodes.
So
And
that
also
means the upper one will only go upper, lower one will only go lower. Is that
Is that
Adam
correct?
first?
no, sir.
Is
No,
that
sir.
correct?
But as per what you said, I understood that the upper one that local lymph nodes and above. The middle one, local lymph nodes. The lower one, local lymph nodes and below. Is that correct? Manmohan,
No, sir.
That
what is
statement
wrong? What
correct.
is wrong?
What is wrong? So how is the lymphatics within the esophagus placed? Are they according to upper, middle, and lower, or they mix up? Are the lymphatics in the esophagus communicating with each other?
Yes, ma'am. They are communicating, they are mixed up. It can drain to
So-
the
Yeah, that's a lymphatic clusters around the esophagus. So it can actually communicate freely.
Yes, they're freely communicating. So therefore, based on the spread, it is very difficult to say where is the primary and esophagus. Though you are conceptually you are right, but in the esophagus you can go wrong if you only go by this conception.
I think 80% can be local or above or below. 20% can go to the any other direction.
Other
That
direction.
is, I think, draft rule.
Hmm. Okay.
Can we proceed? We will
Yes,
ask the next person to investigate. Now we have told this many times. Dr. Manmohan, how will you investigate this case? Anu, please don't show the investigation findings. We want to hear how Dr. Manmohan is going to investigate and then tell us, show us the relevant lab findings. Manmohan, you
Yes,
have
sir.
only 5 minutes.
Yes, sir. One, I would like to investigate to know the general status of the patient and to the disease specific, the condition specific. Sir. For general status, the patient was pale, so I want to see for CBC, complete blood count. So I want to see for anemia and HB, and I would like to see for MCV for the type of anemia, whether microcytic or hypochromic, with peripheral smear in the CBC. Then total count, sir, because lymphoma was one of our differential, whether there is significant total count elevated. I wanted to see. Then other thing is I would like to.
In lymphoma, how often do you get a high total count?
Or less.
Hmm?
less only, ma'am. Less than 10%.
Less than
10%, ma'am.
10%. So if the total count was raised because this patient also had aspiration pneumonia,
Yes,
should we
ma'am.
start thinking of lymphoma?
No, ma'am.
No.
No.
So be careful about what you say.
Okay.
What is more common, aspiration pneumonia or lymphoma in a setting of this patient?
Aspiration pneumonia would be
That
more
is the
common.
cause of increased counts, right?
Increased count. Yes,
You
ma'am.
can look at it like that. Though this patient hasn't got any cough or fever. Okay, next.
Okay. Then other thing would be for seeing, because patient has significant weight loss, general condition, I would also see for in liver function albumin or the total protein and albumin of the patient,
Okay.
and also I'd like to see for alkaline phosphatase and calcium levels in this patient. Okay, because
Okay, 1 minute. Is albumin a liver function test?
no, ma'am. Actually it's for the synthetic
It is for the nutrition that you are looking
nutrition
at.
assessment.
So don't call it a liver function test. What was the next thing you said? Calcium. Why do you
Yes,
want
ma'am.
to see the serum calcium?
In this patient actually we thought of carcinoma esophagus for bony metastasis. And to see for hypercalcemia.
Or again, what is more common, nutritional deficiency or bony metastasis?
Nutritional deficiency is more common.
This patient did not have any pain in the bones, no?
Yes.
Okay, so so therefore you look for it for nutritional deficiency. So what?
Yes, ma'am.
Give me 4 or 5 investigations you will do to assess the nutritional deficiency.
Albumin in blood investigations, albumin of the patient.
Hmm.
Then calcium level.
Hmm.
Then
You
total
said
protein,
hemoglobin.
hemoglobin and total protein.
Same. Okay, anything else?
Mhm.
What about your colleagues? Do they have any other things in mind? What about serum creatinine? Does it help?
Mhm. It tells about the muscle.
What?
Serum creatinine tells about one is renal profile, ma'am, and also about the muscle breakdown.
I
Patient
don't
has to undergo contrast CT, so you have to look for the baseline.
Okay, fine. So now move on. You want to see the.
Okay,
You want- what do you
Anu,
want to
show
do?
the results.
I think that just before you go to the result, just tell what specific investigations you want in this patient. Just specific. These are all for management, no? What specific investigations you want in this patient? Radiological, what investigation do you want? Number one.
First, I'd like for chest X-ray, ma'am.
Chest X-ray, good. Number one. Number two.
Then I want CCT abdomen in radiology.
CCT abdomen.
Sorry, CCT thorax, ma'am. Contrast CT of thorax.
You would go for that straight? You would go straight for a CCT of the chest in this patient, or would you do something else?
Barium swallow, ma'am.
Barium swallow. You're a consultant gastroenterologist. Would we ask for ultrasound at the abdomen?
Yes, ma'am. I'd like to see for ultrasound abdomen.
So what you're supposing there are multiple mets in the liver.
Yes,
Will your diagnosis still hold true, or you think it is?
It still holds true, ma'am.
Yeah, so we already discussed the lymphatic drainage. No?
Lymphatic drainage, yes,
The middle third, lower third, would go to the celiac and can get nodes there. So that tells you it's inoperable, no, straight away. So you ask for that 2 basic tests. Number 2, would you go for a CT test straight in this patient as a gastroenterologist? What would you ask for?
I would like to see for upper J endoscopy. And
you would like to do an upper J endoscopy. What are the things that you keep ready with you? And what are your expectations of this patient when you do an endoscopy?
One is any food stasis, ma'am. So I want to see food stasis in the esophagus. Aspiration. You may aspirate when we're trying to do endoscopy.
You're the registrar on duty. You're asked to do an endoscopy next day. What instructions will you write in the case sheet and how will you proceed with an endoscopy?
Okay. I would like to keep the patient NPO and give IV fluids for the patient. Then Ryle's tube, if possible, ma'am.
Ryle's tube for what?
For esophageal, any food stasis in the esophagus. No?
Why?
Without an endoscopy, you'll pass a Ryle's tube to do what? He's not
Right.
able to eat.
1 minute. Have you seen this happen in your department? That people put a Riles tube before endoscopy?
Endoscopy, yeah.
When you're suspecting a CA esophagus, you don't even know whether the Riles tube will go through.
Sorry. I'll keep patient
So
NPO.
what you have to do is, in this case, I mean, to shorten the whole discussion, I would say that you would do an endoscopy. But what are you going to be careful about when you do an endoscopy? That is what Dr. Jayanti was asking.
And what are the things you keep ready? As you, what are the things you keep ready on the tray? This is the question that's asked. No, you've done endoscopic procedures. So many cases you would have done during your 3 years course. But still, how would you proceed with an endoscopy?
Endoscopy, biopsy forceps, I would keep the ready, ma'am.
So we'll keep biopsy forceps number 1. Number 2, patient is not able to swallow.
Guide wire, ma'am.
Guide by for what? Just tell doctor, what are the things you keep ready? What is your aim? What is your aim in doing an endoscopic procedure in this patient? One is for
luminal obstruction.
One is for diagnosis. One is for diagnosis.
Second,
Number 2,
To
would you like to feed him?
feed in Riles tube, ma'am.
How will you pass the Riles tube? The scope is not passing through. So what will you do?
Dilator, ma'am.
Go on dilator when you give.
CRE.
The more questions we ask, the more problems. I'm asking you a simple question. What are the things you keep ready? What is your expectation and what will you keep ready? So one, define total narrowing. You want to feed the patient. And then you keep guide wires ready. What type of dilators you keep ready?
CRE dilator, ma'am.
CRE dilators in this patient.
what is CRE?
Controlled radial expansion.
So what are the indications for CRE in the esophagus?
Benign stricture.
Sorry, we can't hear you.
Benign stricture.
We are not talking the benign stricture, doctor. We are talking about this particular patient. No?
Yes, ma'am.
Jayanti, are we thinking of having a class for some instruments here?
I don't know.
Yeah, we have a class on 20th. Next week, we have an instrument class. Next Tuesday.
Okay.
Possibly a pediatric endoscopy, normal endoscopy is going along with the SG dilator, biopsy forceps, biopsy brush, and a Riles tube if the patient is not feeding or putting a Riles tube after that.
So you will pass the pediatric endoscope through the mouth or the nose? So it is better to pass it through the nose so that your guide wire directly from the nose, and therefore you don't have to railroad it in later. So it makes your job easier when you want to put the Riles tube. Okay, though you cannot do any dilatation from that, but definitely you can put a feeding tube. Now, the other thing about dilatation, sometimes you don't know how long the stricture is.
Yes, madam.
Okay.
Yes,
So
madam.
therefore, you can just put a Riles tube, then assess the length of the stricture, and then go in for dilatation. Okay. How do you assess the length of the stricture?
Either by barium swallow or by
swallow.
So what is the indication for barium swallow in a CA esophagus? The question is very clear. CA esophagus, in today's day and age, what is the indication of a barium swallow?
Post dilatation, any leak to look for any barium.
In this particular patient,
what is your indication of a barium swallow?
Ahead of endoscopy. Come on, Manmohan, answer. How often have you asked for a barium swallow in your 3 years course?
Before endoscopy.
Before endoscopy. Always? Never?
No, never.
Or sometimes?
Or sometimes?
Sometimes.
So sometimes is which patient?
Which time? What are the cases? These are the classical Viva questions. Classical. Move on. Can we have Can you tell us what was the chest X-ray and let's move on?
Okay, Anup.
You have a chest X-ray?
Go straight for chest X-ray. This
Okay,
time
we
I
go for
requested.
specific ones.
Specific, yeah. What was the chest X-ray?
Chest
The
X-ray was
CT have
normal.
done a chest X-ray. They have done a CT chest, and
CT
which is
chest, yeah.
correct. So you can do a CT chest either with or without oral contrast. Okay, then you don't need a barium.
Yes.
And you
Oh,
don't do the barium before the endoscopy because
Will not be able to withdraw. Suck in them.
you'll see only barium during the endoscopy. It will hinder your. Somebody's just said that.
Yes, madam.
Now, what do
I
you
think
see?
barium will be coating the mucosa, and especially you won't be able to see. You won't be able
See anything. Same
to take
thing for
biopsy,
sucralfate.
etc.
Same thing for sucralfate. Do not give sucralfate to your dysphagia patients. Endoscopy will be completely hindered. What do you
Yes,
see in this patient?
Can we have the endoscopy first? Endoscopy.
I think
Show us
endoscopy was shown first. But because we
Anup,
asked
go
for
back and
extra-
show us the endoscopy. Okay.
Describe the lesion.
There is a at the G junction. There is a ulcerative proliferative lesion. Which
There it
causing
is, fundy growth. Look at that.
Fundy growth, sir. Fundy growth. Ulcerative proliferative lesion, which surface erythema and ulcerations are there. So it was extending from 37 centimeter up to 40 centimeter.
So what CVARS is it?
Growth extent. Seawards 2, ma'am, it comes because the growth is extending less than 2 centimeter into the fundus of the stomach. Seawards 2.
So it's most likely a fundy growth extending into the OG junction. That is why we said none of us know the case as you were discussing. So most important differential diagnosis of a CA esophagus is also a fundy growth. Most important. And you must know the CVARS classification. Here they will hold on. Okay, they'll say it's a G growth that's extending in the fundus, the fundus going in the early. It's all subtle, but if you don't answer, it's fine. But know the CVARS classification. So now, what was a biopsy report? We need to know the biopsy report. What do you expect, Dr. Manmohan? You think it's just squamous or you think it I don't know. Don't just wait for that.
Don't display it, please.
Adenocarcinoma.
Adenocarcinoma. So most probably it's adenocarcinoma. Now, so now you suppose you've got it as moderately differential adenocarcinoma. What will be your next investigation? What will be your next investigation? You've done an endoscopy.
CT contrast.
Involving
Contrast CT abdomen.
Now, Ramya,
neck,
Ramya, please take over. Ramya.
neck, chest and abdomen. Neck, chest and abdomen. CT should involve all the three.
What is the role of PET CT here?
PET CT helps in PET CT helps in assessing for the distant metastasis. And the location, the distance, whether it's a localized disease or there is a distant metastasis, that will be able to localize with PET CT.
Okay, CT mainly for T2 lesion before giving neoadjuvant chemotherapy to look for the response after the neoadjuvant chemotherapy.
Okay. So let's see what the CT says and somebody can read it for us.
Show us the
Ramya,
CT.
do you want to read? Ramya, please show the CT scan.
Yes, sir.
Can you read the CT?
Ramya, please read the CT scan. Whatever pictures
There is
available.
a irregular thickening noted at the lower G junction with multiple perigastric nodes.
Where do you see the nodes are
I
seen?
can't see the nodes. Where are the nodes?
What is happening to the esophagus? Is dilated or it is normal?
It's usually dilated.
Now, why is it dilated? Why is a fundic growth causing dilatation of the esophagus?
It's a pseudoeclasia.
What is pseudoeclasia? What is secondary eclasia? What is pseudoeclasia? You said pseudoeclasia. Now tell me what is pseudoeclasia? What is secondary eclasia?
Carcinoma at the G junction, there is infiltration of
That is not pseudo. What are the causes of pseudoeclasia? When all can you get pseudo? Now, when you answer like this, just read all that you're answering, okay? Read what is pseudoeclasia, what is secondary eclasia. Most probably there'll be notes there, no? See that notes that will be compressing. And it's involving that and it's causing an upfront dilatation of the proximal. So it's causing a secondary eclasia like picture. You understood?
Anup, can you read out can you show the CT so that Remy can read out the official report? Okay, Remy.
Symmetric nodular wall thickening in the region of G junction. Multiple enlarged perigastric lymph nodes, probably metastatic. Few small nodules in the right lung, which are indeterminate, and few small cysts in the bilateral lung fields. Paraseptal emphysema in apical segment of bilateral lung upper lobes. Moderately defined nodule with calcification in the right chest wall, possibly benign, and few small hypodense lesions in both lobes of the liver, possibly cysts. Small fatty density lesion in the upper pole of the left kidney, query angiomyolipoma. So it's a carcinoma G junction with nodal metastasis.
So what stage is it? What's the stage of the disease? What stage is it?
What kind of staging are you going to use in this?
TNM staging.
TNM staging. So what is the T stage?
Tumor is probably
T4.
Is it fairly well described to do a TNM staging with a CT?
EUS.
CT, I think for the staging part, I think it's not that well clearly mentioned. No? It is many of the areas are not enough for a TNM staging. The descriptive findings are little vague. Okay.
So you got you know that there are nodes
We
positive.
would have liked to know the extension of the esophageal lesion, how far it affect the entire locally. Nodes are there. Nodes are there. Okay.
nodal will
Suppose
be
we presume that it is confined to esophagus. Nodes are there. No
nodal will be
metastasis.
N3.
No distant metastasis.
And no distant metastasis is M0.
We don't know whether there are any distant
We do
metastases.
not know. We do not know. We only know about the lung.
Not know.
Yeah.
We don't. We also know a part of the liver, but we don't know everything else.
We don't have other
There
information.
are some small hypodense lesions in both lobes. Probably cysts is what they've written.
So what should you do now? Quick management 1, 2, 3, 4.
To decide on the operability of the case because of the N3 nodes, probably this is a case which is for more for palliation and not for surgery.
Any new adjuvant?
Ma'am?
Any new role of new adjuvant?
Neoadjuvant chemotherapy, chemoradiation has a role.
Now, all that you have to answer. No? So not just tell how to manage this patient. 53-year-old, no? You have to salvage him. You want him to live. So I think you can summarize and tell what they should read. No? That these are the things that will be asked. Even though it is all local. So you do a PET CT, ensure that there's no further metastasis, and then take a call. What will be the role of neoadjuvant? Then you have the HER2 mutation that you have to look for. Then you look for the drugs that can be used in such patients. What will be the regimen? What's the role of neoadjuvant? Upfront, how much will it help the patient? And then whether it can downstage the disease, and then you can go for a resection. Today, major advances are taking place in both rectal cancer and lower esophageal or gastric malignancy, where upfront they're going for a chemoradiotherapy. Chemo-RT, and then you proceed for a surgery. No one leaves them alone. We don't leave the patient alone saying that nothing is possible and we go for palliation. You mentioned the word palliation. How are you palliating?
Endoscopic mode of palliation using SEMS to relieve the dysphagia.
What SEMS?
What sense?
Covered self-expanding metal stent.
It is a distal end. It's a fundy growth. It's a fundy growth. SEMS, what length, what type, what BT and Shobna, you can ask those questions.
So do you think the fundic growth is a good place to place a covered
Sense.
stent?
Sense, yeah.
Covered. The stent will not stay there, no? It will slip. Somebody said anti-reflux. So
This
the
is
patient will
total-
have reflux, no?
This is
So-
the funding growth, total funding growth.
Fundic growth. So your first aim is to feed this patient.
So
In
it
the
will be
stent, there will be reflux. There will be the stent will slip if it's a covered stent. Okay, it's not going to stay there.
jejunostomy tube feeding.
No, you can place a rice tube. You dilate it, place a rice tube, start feeding the patient,
Correct.
then proceed for a chemo RT. Discuss, we need a multidisciplinary approach. Talk to the radiation oncologist, talk to the other oncologist, the medical oncologist, and have the surgical team with you, and then take a call. What will be the line of management? You understand? It has to be because the patient is young, 52-year-old. And whatever nodes he has is all just perigastric nodes. It's not a distant metastasis as far as this is concerned. Okay, so you have to have a multi-skill team, and then you as a consultant at that point of time when you're appearing for the exam, you should know everything about this. What will be the role of chemo RT? They'll ask you about HER2 mutation. They'll ask you about the prevention. Then you'll have to mention about the screening for hepatitis B virus infection. Suddenly there'll be reactivation there. These are some of the offshoot questions that are asked in a patient who needs a chemo RT. Are you understanding? Yeah, what will be the surgical option in this patient? Supposing the patient is fit for surgery, do a chemo RT, there's reduction in the growth. What will be the surgery?
Trans-hiatal extended esophagectomy, ma'am. Because it severts to.
Yeah, so you'll have to do almost a subtotal gastrectomy and then do a pull through and then do an anastomosis. Yeah.
With stomach as a conduit.
Yeah. So read all these guidelines. No, you have to read the guidelines. As far as exam is concerned, you have to know they will ask you to draw the lymphatic drainage, which I think was also your theory paper. See that you know the lymphatic drainage, very poorly written in the exam. See that you know the lymphatic drainage, and we already discussed the esophagus, which are the nodes, which is, when will you say it's advanced malignancy? Middle third into the celiac is advanced malignancy. And then you have to know everything about HER2 mutation, various studies. I don't know, these students, they just put on and God only knows. I don't know whether we are taking some genuine class or just shouting in. They're just within and all just making noise.
Okay. I think Jayanti, is that okay? Now, can we close now?
Yeah, I think we had
VT? Yeah, VT just
we had a very
summary.
long session. Shobhana ma'am.
Yes. Thank you, all of you.
Shobhana ma'am, just tell us the important aspect about the case and what summarize the
First
case.
of all,
Shobhana
when
ma'am.
you talk of dysphagia, when you have a patient with dysphagia, the first thing in the history you have to, in your own way, clarify that you are looking at a person who has a mechanical or a motor dysphagia or a neurological dysphagia. From your history, from the first 4 lines, it should be clear what you are dealing with. If you are dealing with a case which is purely mechanical dysphagia, don't bring in neurological and motor dysphagia differentials or negative points also. In the first few sentences, it is clear. So don't keep on lengthening your negative histories. Once you have come to dysphagia, now come with the associated symptoms, which will be heartburn, regurgitation, chest pain, maybe sour regurgitation, aspiration, all that. Just mention those quickly as negative. Then when you come to weight loss, and which is so significant, you've already pinned the diagnosis as a mechanical dysphagia, which is most likely to be a malignant case. So then don't waver from there. In the management also, though older textbooks do mention that barium should be done, in the current scenario with slim scopes being available and the risk of complications of endoscopy being very low, we now hardly ever go in for a barium before endoscopy. The endoscope is the thing that you used to use into determining where is the what is the cause of the dysphagia. You can also provide treatment at this point. If you see a little bit of lumen where your pediatric scope can go through, in this case, for example, the scope has actually gone into the fundus and you can see it. So then for a severe dysphagia, you can easily pass a Riles tube at this point and give at least nutrition to the patient. So then you can talk of other investigations after the endoscopy, and other investigation should straight away go to looking at the stage of the tumor. You're trying to see how big the tumor is, whether there are lymph nodes, whether there are any vascular involvements in some cases, whether it is involving the trachea, whether it is sitting on the aorta. All those things are important. So you look at all these things and then come straight to the management, whether it is CTRT or the patient will get first surgery, depending on the condition and whether there are any complications. So for example, if there is already a fistula, CTRT is going to actually cause worse problems. So in that case, you might actually think of doing something beforehand to close the fistula and then go for other modalities. So all these things should be very clear in your mind. And your eventual aim is to see how best you can help the patient. Okay. So that is how you answer questions and that is how you will manage the patients in your daily life. This is how I would put it. Any other points, Jayanti?
Drop space dullness, sir. Clinical examination, drop space dullness in this patient.
Okay, sorry, I missed that. Sorry, I missed that. Yeah.
Because
Okay.
this is what I'm giving you a clue. Drop space should not be dull in this patient.
Yes.
We're giving you a clue to a diagnosis. We keep talking about drop space, but it's very relevant in this particular case. Okay.
Okay.
Thank you. That is wonderful. Thank you very much, Shobana ma'am.
Yeah.
Shobana ma'am, we could not
Thank
introduce you because you came a little late. Shobana ma'am is the
No
senior
problem.
consultant of Sir HN Reliance Foundation Hospital, and she is the director of neuromotility. The students, you don't have any better person to discuss the dysphagia than Shobana ma'am in India, because she is basically a luminal gastroenterology interested person and with a very specific interest in esophageal disorders. And she is currently the director of neuromotility research in that institution. She was formerly the professor and head of KM and Seth Medical College, Mumbai. Thank you, ma'am. Thank you very much for joining us. And we look forward to wonderful cooperation in future as well. Thank you, Jayanti ma'am, for your
Bye-bye.
very useful
you.
class. In the initial part, you were the only leading faculty. So thank you very much, Jayanti ma'am.
Thank
And
you.
thank you, Anu, Manmohan, and Ramya for participating in today's case. And I have to thank Clarinet for providing this platform free of cost. And Mr. Faraz has been with us for last 2.5 hours, helping us technically. Thank you, Mr. Faraz, and thank you each and everyone. Our next class from Tamil Nadu side will be on Thursday. Next, Professor Venkatakrishnan will be taking. And from Kerala side, we will have an instrument class on 20th and another clinics on 27th. And Professor Venkatakrishnan will have one more clinics on another Thursday. I think 2 clinics are pending from Tamil Nadu side. That will be done. Okay. So thank you all once again. And good night.
Good night. Good night.
Thank you, ma'am.
everyone.
Thank you,
Good
sir.
night. Take care. And for all your permission, we are closing here. Thank you so much.
Okay.
Thank you, ma'am.
Good night.
Recording
Thank you.
stopped.
Thank you very